Okay, I think we can call the meeting to order, and if you'll rise with me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Great to see you all. Dee, if you could call the roll, please.
Director Nicholson.
Present.
Director Yee.
Present.
Director Stewart.
Present.
Director Epen.
Present.
Director Wallace.
Present.
And Director Nicholson here in the boardroom. We have Kimberly Hartz, Chris Henry, Tina Nunez, Stephanie Williams, Paul Kozachenko, Shri Bodu, and me, Dee Antonio.
Thank you very much, Dee. Welcome to the March 10th, 2021 regular meeting of the Washington Township Healthcare District Board of Directors. To comply with Alameda County's Order Number 2101, as issued on January 25, 2021, to comply with social distancing measures and other restrictions necessary to control the spread of COVID-19. This meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. Governor Newsom's Executive Order N-2920 explicitly waives the Brown Act provision that requires the physical presence of members, the clerk, or of the public as a condition of participation in or quorum for a public meeting. We continue to comply with the Brown Act in providing dial-in information in order to provide the public the opportunity to attend the meeting. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. I will now move to the oral communications, or the communications section of our agenda. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none. Dee, is there any written communication?
There is not.
Very good. We'll now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the agenda action item heading of the agenda. Does anybody on the board want to remove an agenda item from the consent calendar? Hearing none, does any member of the public want to remove an agenda item from the consent calendar? Hearing none, may I have a motion to approve consent calendar items A through C?
Mr. President, in accordance with the district law policies and procedures, I move that the board approve the consent calendar items A through C.
Thank you. The second was from Director Wallace?
Yes.
Oh, good. Okay, thank you. Dee, if you could call the roll.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Director Wallace.
Aye.
Okay, consent calendar is passed. We'll now move on to our education session. Kimberly, if you could introduce Dr. Yoshida.
Yes, good evening. It's my pleasure to introduce Dr. Emi Yoshida. She is a radiation oncologist who specializes in the treatment of gynecologic and breast malignancies with expertise in HDR brachytherapy. Her clinical and research focus is on radiation-related toxicity and methods of improving the therapeutic ratio. She's particularly interested in incorporating patient-reported quality of life outcomes into routine clinical practice and into clinical research endpoints. Dr. Yoshida earned her medical degree from the University of California, Davis, where she was awarded a Medical Student Research Fellowship and Medical Scholars Award. She completed an internal medicine internship at Kaiser Oakland. She then completed residency at Cedars-Sinai Medical Center, where she was awarded the International Atomic Energy Agency Ambassadorship and the Leo G. Rigler Award for Outstanding Academic Achievement. She is a UCSF faculty member and serves as the medical director of the UCSF Washington Hospital Radiation Oncology Center, where she treats patients who have malignancies of all disease sites. She is actively building the UCSF Washington Cancer Center clinical trials program and is developing a stereotactic radiosurgery and stereotactic body radiotherapy program. And pleased to introduce her, and she's going to talk about some changes we have made at the Radiation Oncology Center. So thank you for joining us, Dr. Yoshida.
Hi, thanks so much for having me. So I'm going to share my screen. And please let me know if there are any technical issues.
Looks good.
Okay, great. Okay. Again, thank you for the introduction. My name's Emi Yoshida. I'm the medical director at The Rock, and thank you for letting me speak today. So I wanted to give some updates about The Rock, give a brief background about radiation and its history, brag a little bit about some of our new TrueBeam capabilities, and discuss our future directions. So this is our old machine in our old treatment vault in 2019. You can see this lovely carpet. And here's our beautiful new TrueBeam and our newly renovated treatment vault. We've been treating on this machine for nearly 3 months now, and it's really been nothing short of a wonderful experience for the patients, the staff, and the physicians. I wanted to give a sense of our volume on the TrueBeam, but since we only have 2 months of complete data to compare with prior years, I decided to just compare last month's volume with the month of February's volume over the past 3 years. I realize that this is just a small snapshot in time, and there are fluctuations in radiation oncology, but suffice it to say that last month we had an average of 19 patients on treatment per day. During February of last year, we were settled in our temporary location in Hayward, and we're averaging 16 patients treated per day. In February 2019, we were sort of at the cusp of transitioning to a joint UCSF Washington radiation program, at which time we were treating 15 patients per day. And then in February of 2018, we were averaging 11 patients per day. So while I realize this is just a glimpse of our patient volume over time, I think that there's an overall trend towards increasing volume, which is really exciting. I thought I'd also use this opportunity to give a brief background on radiation oncology and its importance in cancer care. Radiation is one of the 3 main treatment modalities for cancer, and the other 2, of course, being surgery and chemotherapy. We use ionizing radiation, meaning radiation that creates charged particles to cause DNA damage and eventually elicit cancer cell death. This mechanism of inducing cancer cell death is similar to how chemotherapy treats cancer. Also similar to chemotherapy, the intensity of treatment can be modified by altering the overall dose or the daily dose. However, radiation is localized to the area that we specify, which is more akin to surgery, albeit non-invasive. And unique to radiation oncology is that we can use our cancer treatment to also palliate symptoms with the goal of improving quality of life. But patients always ask me, if radiation damages DNA and kills cancer cells, what's stopping it from damaging and killing my normal cells? Radiation actually takes advantage of a fundamental difference between normal cells and cancer cells. It damages the DNA of both cell types, actually, but healthy cells are able to repair the DNA damage before they go on to replicate and prevent inherited damage. Cancer cells have a limited ability to repair DNA damage, and so they pass on this damage to their daughter cells, and the accumulation of unrepaired damage eventually results in the cell's inability to replicate, and the cancer cell will eventually die. So how is ionizing radiation made and delivered? It's either produced by radioactive decay or it's created by acceleration of charged particles. Historically, the most commonly used radionuclide has been cobalt-60, which is the same radionuclide we use in the Gamma knife machine. However, in the past 30 years, the majority of the original cobalt machines have been replaced by linear accelerators. Here you can see electrons are generated by an electron gun that are accelerated very quickly down the head of the machine using alternating microwave fields. The accelerated electrons slam into a high Z target like tungsten, which generates photons or X-rays. The photons are then directed with magnets out of the head of the machine in a shape that's created by a combination of large lead or tungsten blocks. And then the shape is further defined by narrow tungsten leaves that are, it's called a multi-leaf collimator. And it shapes the beam as it exits the head of the machine before entering the patient. So a brief history of radiation. In 1956, the first medical linear accelerator in the United States was developed and installed at Stanford University under the direction of Dr. Henry Kaplan and a physicist named Mitchell Weisbluth. The first patient to receive radiation was this little boy here. His name was Gordon Isaacs, and he was a 2-year-old boy with retinoblastoma, a malignant tumor in his right eye. The tumor was threatening his vision in his left eye, and thankfully they were able to save the child's left vision using radiation, and he went on to live the rest of his life with his sight intact. Prior to the 1970s, radiation was mainly delivered in just 2 planes, front to back or side to side. X-rays were taken in these directions, and then the films were developed. They were placed on a light box, and the radiation oncologist would physically draw the shape of the field that they wanted to treat using a wax crayon onto the actual X-ray. Then blocks were cut to place in the field of the beam in order to generate a certain shape. And the depth of the treatment was estimated by measuring the width of the patient in the location of the tumor and then estimating that depth of the tumor. By today's standards, this was a very simplistic, but actually very effective method of delivering radiation. However, as you can imagine, it was also very toxic given the difficulty of being able to reduce radiation to surrounding normal tissues. In other words, we couldn't conform the radiation in shape and dose to the target volume. But the introduction of the CT scanner in the early 1970s was key to the development of modern 3D planning because it provided a complete 3D description of the anatomy of each individual patient, which could be used as the basis for radiation planning. It allowed us to more accurately delineate the target volume, which you can see here in red is the oral pharynx, as well as surrounding normal tissue, such as the spinal cord in the back, the parotid glands here on the side, and then the oral cavity in the front. And it gave us the ability to deliver radiation at multiple angles around the patient in 3 dimensions. This, in combination with the invention of the multi-leaf collimator around the mid-1980s, made possible the delivery of very complex plans, including those that make use of modulated beam intensities. So in other words, by the mid-90s, we could create a beam that not only had a particular shape, but also had different intensities within it by using the dynamic motion of these tungsten leaves to block portions of the beam at varying lengths of time while the beam was turned on. And so here's a comparison of progressively more conformal treatment plans on the same CT slice. So again, the target is delineated in red. And the initial plan is just 2D radiation. So the beams were delivered from either side of the patient with just a square field. And you can see that the target is, very well covered. The color wash represents the radiation dose. So the target is covered well, but you can see the parotids on both sides and the spinal cord, and most of the oral cavity are getting the full dose of radiation. Here with this 3D treatment plan, you can see that the target is still well covered, but there's complete sparing of the spinal cord, and then partial sparing of some of the parotid glands, and then some partial sparing of the oral cavity. And then the last plan on the right is the IMRT plan. And here you can see almost complete sparing of the parotid glands and of the oral cavity, definitely of the spinal cord. And actually, there's really good conformality of the dose, the radiation dose to the target volume. An IMRT compared to 3D conformal radiation has been shown in multiple randomized control trials to reduce dose to normal tissue, which translates to less toxicity and better quality of life for our patients. And finally, what brings us to today and what separates our current technology from our prior machine is the ability to deliver intensity modulated radiotherapy while the gantry, or the head of the machine, is actively moving around the patient. In effect, we're able to deliver small beamlets of radiation from every angle in 360 degrees around the patient, either all in one plane, as shown here, or in multiple planes. And these small beamlets are each individual shapes and intensities, all converging on a target to create a very complex volume and radiation dose distribution. And this is called volumetric modulated arc therapy, or VMAT. So other than VMAT, what are some other capabilities of our new TrueBeam? In order to ensure accurate setup of the patients every day, we often take pre-treatment images to ensure the anatomy on the treatment day aligns appropriately with the anatomy on the day of radiation planning. So on our old machine, we were only able to take very limited 2D images of our patients for verification of their positioning. This is an example of a patient whose prostate I was treating in 2019. These two upper images are computer-generated images from the CT scan we used for radiation planning. And these 3 dots here and here are gold fiducial markers that were placed inside the prostate for us to be able to match to every single day. And these 2 images here on the bottom are, represent just one of the daily images that we would take on the machine itself every day. And you can see that, these onboard images, you can sort of make out the bony structure, but in no way can you see, the target, which is the prostate itself, or, the sort of nearby critical structures like the bladder and the rectum. And even though they have gold fiducial markers, it's still hard to see them. So, this is what our onboard imaging looks like today. Our new TrueBeam has a CT scanner that is mounted onto the gantry, and it's able to very rapidly do a CT scan prior to delivery of radiation. So these top 3 images are the original planning CT, and these bottom 3 images are just the daily CT scan that's taken to verify the patient's position. And in some ways, it's actually even hard to tell the difference between the diagnostic CT and the CT that we use just for, for positional verification. And we can even, in this case, make sure that the rectum is out of the way and make sure that the bladder is appropriately out of the way. But what good is accurate, pre-treatment imaging if we can't move the patient to the appropriate location we want them to be in? So previously, once the pre-treatment images were taken, the therapist needed to go into the room and physically shift the treatment table to the appropriate location. The old treatment table could only move in 3 directions: in, out, up, down, and side to side. So the X, Y, and Z axis. Our new treatment table is completely automated, so it can be moved from the treatment console, which is outside the treatment room, which saves quite a bit of time for the therapists. And it also now has 3 additional directions in which the patient can be shifted in order to ensure accurate setup. So I'm not sure if any of you are pilots, in which case you already know this terminology, but the table can roll, pitch, and yaw up to 6 degrees. And all of this technology allows us to perform complex treatment delivery, like stereotactic body radiotherapy or SBRT. And SBRT uses a high dose per fraction, usually between 1 and 5 treatments, to ablate tumor cells, which means that compared to conventional radiation, it requires a much smaller margin of error and a much steeper dose fall off to spare normal tissue. Here's some images of the treatment plans for SBRT and what they can look like. So treating a very small area with high doses of radiation and really minimizing dose to surrounding tissue. And I'm proud to say that we treated our first SBRT brain case last week successfully, which I'm sure is the first of many to come. So I'll just quickly touch base on future directions at the ROC. In the future, we hope to continue to minimize side effects from radiation by managing the treatment of mobile targets in the body. So here you can see there's a gold marker that is delineating a small liver mass, and that's being treated by radiation. So although the mass is small, the area that has to be treated in red is rather large because we need to account for the motion of the liver during respiration while the radiation beam is on. You can see that this means more liver is being treated, more healthy liver, and then even a fair amount of lung is being treated unnecessarily. So we will eventually be able to account for the motion of these tumors through fiducial marker tracking and beam gating, which turns the beam on only when the tumor is in a pre-specified location during respiration. So in other words, the beam only turns on when the tumor is in the right place at the right time. Or we can limit the motion of organs themselves by treating patients using a breath hold device. Here you can see the outlines of the heart at different positions during a regular respiratory cycle. And if we treat, for example, the left breast, while a patient holds her breath, we can limit the amount of heart dose by only treating her when the heart is away from the chest wall. And this is a friend of mine actually going through breast irradiation. You can see that she's getting left-sided breast treatment. She breathes through a device that's able to monitor the volume of air she inspires and expires. And then this volume is visualized on this screen next to her. And the beam only turns on when she takes a deep breath and holds a pre-specified volume of air. So I just wanted to acknowledge everyone I work with at the ROC and at UCSF. We have a really wonderful team and I'm honored to be a part of it. Thank you so much for your time and happy to take any questions.
Thank you, Dr. Yoshida. Any questions from the board members?
I was curious about the overall lifespan of the machine.
I mean, the machine itself can last for a very long time. The truth of the matter is it's often, it's often the technological advancement that really, causes the machine's age, if you will. So, it's not like, the older machines that had cobalt sources in it where you had to replace the source every so often or things like that. This machine will probably continue to work for many decades if we wanted it to.
Thank you. Any other questions? I have a question. How does this machine with SBRT compare to the Gamma knife and the so-called cyber knife?
Yeah, that's a good question. So we don't have great data comparing the different treatment devices or treatment machines. I mean, it's just, unfortunately, so hard to run a good trial that way. But, based on multiple retrospective studies, we think that it is as good as the Gamma knife at treating most brain lesions. The Gamma knife, of course, has the benefit of having, your head fixed with an actual, immobilization device. And so, in truth, I think the accuracy of the machine is quite similar. It's just that, we also have to account for some movement of the patient. And that means that, we need to have a little bit of a margin, just because, we don't fix patients on the table. The CyberKnife actually tracks fiducial markers as it's treating in real time. So, our current machine is not built to do that, but there are add-on things that you could get if you wanted one day to do that.
Mhm. Okay, thank you very much, Dr. Ishida. We appreciate the very informative presentation, and we're glad to have you here. And so thank you so much.
Thanks so much for having me.
Okay, our next agenda item is our medical staff report from Dr. Killaroo. Are you with us, Prasad? You're on mute if you can hear me.
Or I see Dr. Killaroo, are you on? Are you going to give the report?
Can you hear me? Hello, can you
Yeah,
hear me?
now we can hear you.
Now we
Hello?
can hear you.
Okay, sorry. I was trying to do three things at once. I apologize. Yes, so just as a quick, from the medical staff numbers, we have a total of 582 members in the medical staff, 355 of which are active, and we have 97 ambulatory members. We had our quarterly medical staff meeting yesterday. We are we are also in the process of starting the election for the new leadership, mainly the medical staff liaison officer, as well as the chief of staff elect will be up in both of those positions. Right now, we have one nominee for each of those positions. We have Dr. Mark Saleh, who's the urologist, nominated for the chief of staff elect position, and Dr. Tim Choi, who's the current past chief of staff elected for the liaison, or nominated for the liaison position. We are in the process of trying to coordinate the annual dinner dance with COVID, with the restrictions. We're not quite sure where and how that's going to be done, but hope to have that information soon, and either towards the end of May or in June, we'll be having that function. That's my report.
Thank you very much, Dr. Killaroo. It's probably going to be a social distancing dance.
Yes. We're trying to figure out how to do it where we can still meet everybody and thank them for all the work that they've done in the last year and more so.
Great. That's good to hear. Thank you again.
Thank you.
Okay, we'll move on to our Service League report and welcome Debbie Fury, our new Service League president. Welcome, Debbie.
Yes, I would.
Thank you.
Yes, and before Debbie, why don't I give a little bit of I have a little bio on you so that everybody knows a little bit more about you. Debbie was recently installed as president of the Service League. She was born in Castro Valley and graduated from American High School in Fremont. She began her professional life as a truck driver before going to nursing school and becoming a cardiac care nurse. She worked as a medical staffing supervisor for a large home health agency before retiring. After her retirement, Debbie wanted to give back and began volunteering with the Red Cross. She volunteered as a workforce supervisor on a disaster action team that responded to local wildfires and helped rescuees. She is also an active member of the Community Emergency Response Team in Hayward, where she lives. And of course, she has volunteered at Washington Hospital with the Service League since 2019. Debbie has 3 children, all born at Washington Hospital, and 5 grandchildren. She enjoys time with her family and traveling with her husband, Ron. So welcome, Debbie, to the role of president and to our board meeting this evening.
Thank you, Kimberly. That was really sweet. I just wanted to, we had the annual meeting in late February and the board has changed a little bit. Ruth, I want to thank her because she was awesome and actually pushed me into wanting, doing this role. So, but I still depend on her. But it was voted in for the new officers for the 21-22 fiscal year. President is Debbie Fury, myself. First vice president is Sheila Vijay. Second vice president is Fee Wong. Secretary is Diane Zariski. Treasurer is Sydney Margolis. And parliamentarian is Gail Tomamita. And so during this pandemic, as everybody knows, the volunteers have been very limited on what we can do, and we're doing special projects. So there's some of us that have come back, and so we're building the COVID-19 kits for the lab. We're labeling the empty syringes for the pharmacy. We're assisting community members in the vaccination clinic. And we're also we're doing we're filing documents in the HR, and we have the gift shop open 3 days a week for 3 hours a day, which I think has brought morale up a little. Especially when we go to open and there's a line from the staff, which is really nice because they support us a lot and we really appreciate it. We did do the gift shop in spring motif, so but we are still doing the COVID distancing to keep everybody safe. And that's it for my report for March.
Well,
is there any questions?
any questions, any comments? No, we're just so great. We're so grateful for all the work that the Service League has been doing during the COVID pandemic. And we know you guys are going to be a lot busier as things open up and the volunteers return to the floors and the front desk. We need you and want you. So we're grateful for what you've been doing for us, and we really look forward to what is to come. So thank you, and welcome aboard in your new position. We look forward to many more great reports.
Thank you so much.
Thank you, David. Okay, we're going to now move on to our quality report with Mary Bowron presenting the quarterly quality dashboard.
Okay, great. Thank you. Good evening. Tonight, I'll be presenting the quality dashboard for quarter ending December 2020. So this will cover October, November, and December of 2020. I think it's all basically outcomes focused, and we have some great outcomes to celebrate, and then some other areas that we'll be working on. Starting with the first slide, we're going to the infection prevention indicators. We have continued to see 0 hospital-associated MRSA infections. This is defined with patients who have MRSA in their blood after 3 days of being admitted. And so that continues to be at 0, which is good. And moving on to the next slide, VRE, also 0 infections. So that's a decrease from the prior quarter. Next slide. For our central line associated bloodstream infections, we had seen an increase for 2 quarters prior to this one. And so the nursing team worked very closely with some medical staff leadership and sort of looked at some root causes and decided to focus on a bundled approach to reducing the risk of central line associated bloodstream infections by reducing the days that the line is in place, and also making sure that we're doing all of the appropriate care and maintenance of the lines while patients do need them in the hospital. And we have been able to bring that down to 0 this last quarter. So that was a great accomplishment for that team who worked on that. Moving into county. This is a catheter-associated urinary tract infection, and we did have 2 counties this last quarter. It is still a decrease from what was a pretty significant spike the quarter prior to this. And we did a similar approach with reducing county that was taken to reduce the central line associated bloodstream infections. And but in addition to that, we're also using devices that can help patients when they're in the hospital and they need a form of collecting their urine through when we have to measure it, or they can't get up to go to the bathroom, etc. We have other devices that are not actually the catheter line, and we're trying to use those devices when we can to reduce the invasive line being placed. So we have been able to reduce catheter days by doing that, and as a result, appear to be having less catheter-associated urinary tract infections. We're obviously continuing to work on this, and the same team that works on looking at the CLABSIs and the counties with infection control will continue to work on this, because obviously we would like to get this down to 0 moving forward. And next slide. For our C. diff, we have now the 2nd quarter with less than expected number of cases of C. diff. We did have 8. The predicted infections for a hospital of our size and type was 9. So it's 1 less than expected, but we still do take the 8 cases very seriously. They're all reviewed. One of the things that we're looking at is making sure that we test patients appropriately and determine if they have an active infection. And that, of course, changes and makes the treatment for C. diff better for the patient if they have an active infection versus a patient who's just colonized with C. diff and may not need the same treatment path. So we're looking closer into our testing and doing timely testing that's appropriate for patients, and that may even decrease this number further, because some of these could have been colonized, but because we weren't testing at that time for that, we don't know. So that's continuing to work on that. But again, overall, a great deal of success for our 2nd quarter being under the benchmark. So we're happy about that. Moving on to our surgical site infections. This is a great success for the colon surgeries and for the general surgical team here at Washington. We have 0 infections. Again, this is something that is monitored on a federal, state, and local level, because it's a procedure that is high risk for developing surgical site infections. And as you can see, out of 6 quarters, we have only had 1 infection. And this last quarter, we were at 0 again. So great outcome there. Moving into our surgical site infections for abdominal hysterectomy, also 0 infections here. And this is another type of surgical procedure that's monitored on a federal, state, and local level. We have not had any infections here for now 4 quarters in a row. And out of 6 quarters, we've only had 1. So it says a lot about our OR process here. Next slide. Hand hygiene is currently at 85%. While the global World Health Organization has this goal set at 70%. We're above that, of course, at 85%. Joint Commission has a national goal at 90%. We obviously strive to even go above 90%, because hand hygiene is something that we recognize needs to be done consistently at all times, and it's probably even more essential now than it's ever been with the current pandemic we're dealing with. So there is a team of individuals working on this through patient safety, and we will be coming up with a plan for how we're going to do more observations that give us data that kind of tells us why people don't wash their hands. Like, were they interrupted? Was the hand hygiene available at a convenient location, et cetera? All these things that we can learn from, and then use that data to make improvements and use it to hopefully increase our hand hygiene compliance. So we'll continue to be working on that. That's a sustaining initiative that never goes away. We have to continue to work on it every day, and infection control is actively involved in this multi-disc team also. So hoping to get that up above 90% and closer to 100%. Moving into our nursing sensitive indicators. Starting off with our inpatient falls with injury. Our prior quarter, we had seen a rise in falls, and the falls team does a similar approach to what we do with other quality data, which is really looking at the data to see if we can find any trends and identify any issues with what led to the fall. Typically, these are a patient trying to get up. Sometimes if they get up without calling for assistance and they're a little bit more of a risk and unstable, and they fall and sustain an injury, which is what happened in this case last quarter, 12/20/20, when we had one fall. This actual fall, even though it puts us right at the benchmark, is just one fall, but it doesn't take much to go above the national benchmark. And that's a good thing, because even one fall is too many. And so this was a moderate injury. The falls team is looking at that. However, it is a significant decrease from the quarter that we had before. And we actually had a higher number of patients in this last quarter with high acuity. So we were glad to see that this came down even under the circumstances of a surge at the end of and throughout December. Next slide. Hospital-acquired pressure ulcers, very similar here. This is actually one pressure ulcer. We are below the benchmark, and the dotted line there is just a predicted benchmark. That's why we have a dotted red line. The predictive benchmark is 1.56. We're under it by 1.2 is the actual pressure ulcer rate. This is reflective of one stage 2 pressure ulcer. The nurses are very careful in doing skin inspections on patients when they're admitted, and we continue to use the appropriate beds and mattresses for patients who are at risk for developing pressure ulcers. And there's a wound team that looks at these cases, and with this one that's identified, of course, they do a similar process looking at root causes. And this was actually a very sick patient and had been here with a long length of stay. Moving into readmissions. We have seen some area of success with readmissions, and then some areas that have gone up. AMI did go down slightly this last quarter, with 5 patients returning out of 38. That puts us at 13.2%, which is a little under the national benchmark for readmissions for AMI. Pneumonia continues to be our biggest challenge with readmissions. As you can see, we're just having this trend in the wrong direction, going up. We had 20 out of 63 patients readmitted this last quarter. That puts us at 31%. The national benchmark is 16.6. So this was obviously a big concern to the readmissions team. We did look at the 20 patients that came back, because one of the best ways of understanding what's leading to your readmissions is by looking at what causes patients to come back that are here now and have already returned. And so what have we learned by the patients who have been readmitted? And in this case, these 20 patients were actually very sick. 17 of the 20 are age 75 and over, and half of those were in here for a sepsis-related illness, and spend a lot of time in critical care, and we're here for longer lengths of stay. So what we've learned by looking at these patients is, first, we need to prioritize pneumonia, and when we're looking at the patient populations that we want to reduce readmissions for. And in doing that, I think we have some opportunities in transitional care planning, which is basically our team here looking at what we can do to assist patients after discharge to make sure that as they transition back to home or to a skilled nursing facility, are there any gaps that we can help fill in for them? So, such as making sure that they get their medications, making sure that they get into their primary care, and having follow-up phone calls with these patients prior to them seeing their primary care physician. That way we can identify any issues that they may be having at home. In this case, especially looking at their antibiotics, it is considering that a lot of these patients initially came in with pneumonia sepsis. So that requires a lot of support even after discharge. Even if you don't meet for acute care, and now you're transitioning back home, that's good and that's progressing and they're getting better. However, when you're recovering from this level of illness, that patient requires a lot of support. And so what we're also doing is making sure that these patients are getting home health. This is something we're just now starting. It was not happening this quarter. We're actually just starting to work on it this month, identifying ways that these patients can get home health as much as possible. And that way they have support where a caregiver is coming in, really doing a face-to-face visit and assessing their needs, and even maybe social determinants and things that are going on in their life that we can help and support fill in the gaps. It's really important that we establish these relationships with community providers also when we're communicating with them about the care of the patient and what's going on. I think that's going to be key for these patients. It seems that that is where the decline is happening. It's happening early on after their discharge, and they need more support. And it's up to us to offer that to them so that they don't have to face coming back to acute care if they don't need to. So again, this will be a priority group for us moving forward. For heart failure, same thing. We have about 18 out of 79 patients who were readmitted, puts us at 22.8%. So this is, slightly above the national benchmark. We will be using the same approach with heart failure patients as what I referred to with pneumonia patients, because they are probably our second most critical population to focus on for reducing readmissions. Our patients who come into the hospital and have a coronary artery bypass graft, otherwise known as a CABG, have been doing really well with as far as readmissions goes. The last 2 quarters, we have not had any. This is only out of 3 procedures, but we're at 0 for 2 quarters in a row. And also our patients who have their knee or hip replaced. This has been a procedure that we continue to do very well with, related to all across the board with that service line, but especially with readmissions well below the benchmark, and only 2.7% of our patients returning. And in this case, that is 1 patient out of 37. Typically, the national benchmark on this that CMS uses is 4%. So that continues to be a great success for us. For patients who have COPD, this is another challenging area. We had 4 patients out of 17 that came back, putting us at 23.5%, and the national benchmark is 19%. What we've identified by looking at these patients is that if and when they can get to pulmonary rehab, the patients that have pulmonary rehab and qualify for pulmonary rehab and actually get to pulmonary rehab have a lower readmissions rate. And so we are working very closely with the RT team here at the hospital to make sure that they are out and seeing the patients and seeing if they qualify, working with the physician to make sure that the patient gets the pulmonary order prior to discharge. And that will be one of the ways that we can help support the patient further after discharge. And that concludes my report. Thank you.
Thank you, Mary. Any questions from the board members? A lot of good work, Mary. A lot of great results. On the pneumonia readmissions, how much did COVID pneumonia play a factor in that?
Yeah, I'm glad you brought that up because that was our initial response also, was thinking a lot of these probably had COVID, right? I mean, what's interesting in those 20 patients is that there is not a single readmit that is COVID positive.
Okay,
Yeah,
okay. Other things to work on then.
yeah, exactly. Pneumonia volume obviously went up a lot
Yeah.
because
Mhm.
of COVID, but it didn't impact those 20 patients that came back.
Great. Okay, thank you very much. Okay, we'll now move on to our finance report with Chris Henry.
Okay, good evening. Tonight we'll be looking at Washington Hospital's operational and financial results for January 2021. And moving into our operating indicators, again, seeing the same pattern we've seen for most of the year with the relationship between admissions and patient days and average daily census. Admissions in January, 14.1% below the budget, but our patient days and average daily census were 26.9% higher than budget, which again relates to the longer lengths of stay we've been seeing in the hospital. Outpatient observation equivalent days were pretty close to budget, a little bit higher at 179, but our average length of stay really exceptionally high in the month at 7.49. 2.66 above the budget. I do want to note that this average length of stay number is based on discharges as opposed to the patient days, which are the actual days patients were in the hospital during the month. So there's a timing difference there. And we did have some long lengths of stay hit our average length of stay number in January. We had 9 cases, I think Kimberly went over this last month. We had 9 cases that were discharged that had stayed over 60 days. One of those had stayed 84 days, one had stayed 96 days, and one had stayed 276 days. So some exceptionally long lengths of stay included in that number for January. A lot of that's related to the severity of the patients we saw during the month. If I can get the slide to advance. Case mix index for January, higher than I have ever seen it in my 21 years here at Washington Hospital at 1.743 against a budget of 1.431. You know, generally when we're seeing a case mix index of 1.5 or more, we're saying, you know, we have some really sick people in the hospital. At 1.743, we really did have some very ill folks in the hospital, and that contributed to those long lengths of stay. Deliveries for the month came in at 91. We'd expected 143 in the budget. And again, I think this is something that we're seeing not only regionally, but statewide and possibly nationally. I think folks are just really putting off having babies during this difficult period in our history. Surgical cases for the month were 78 below budget at 286. Again, in January, because of the level of COVID patients we had in the house, we started curtailing elective surgeries, and so that volume lower. Cath lab procedures, likewise, 16 below budget at 330. Our outpatient visits that we've seen this year lower than budget by 754 at 6,571. The big drivers there for the month was X-ray and cardiac rehab driving the majority of that variance. Emergency visits for the month continued to be lower than we expected at 3,712. And we had no RSTU visits in January. We had shut down the RSTU at this point. A quick look at our surgical and cath lab detail. Surgical cases, variance really driven across the board, but joint replacements were the most impacted. I think they again, because of the curtailment of elective procedures, it really impacted those procedures in particular. Also, general surgery procedures were off by 34. In the cath lab, you know, we had a variance of 16. A couple of offsets there in cardiac procedures being 32 below budget, but our neurointerventional radiology procedures being 14 higher than budget, so pretty busy in that product line. We've got Okay, I'm there, Sri. I got it. So productive FTEs, moving into productivity, productive FTEs for the month came in 130.9 above the budget at 1,381.2. We had 180.6 non-productive FTEs, rounding things out with total FTEs that were 128.9 above the budget at 1,561.8. Our FTEs per AOB for the month came in lower than we had anticipated at 6.09. We'd expected 6.37. So again, a little bit short on FTEs for the month, but that was help for the bottom line. And moving into the financials, total patient revenue for the month came in 9.3% above the budget at $185,115,000. Our deductions from revenue were unfavorable for the month at 78.82%. We'd expected 77.65%. That variance made up of our contractual allowance, which is our government-sponsored patients and HMO and PPO patients. Government-sponsored patients really came in higher than we've, I think, ever seen it at 77% versus a budget of 71.2% of gross revenue, while PPO came in lower, much lower than budget at 18.9%. We had anticipated 24.2% of gross revenue for the month. That variance alone in contractuals really impacted the bottom line by $3.1 million. We did have a little help from our private pay. Private pay for the month came in at 0.7% of gross revenue versus a budget of 2%. That gained us back about $900,000. So net at 78.82% versus 77.65%. The impact of that's about $2.2 million for the month. Moving into operating expense, So we ended up with net operating revenue just a little bit short of $1.5 million, higher than budget at $39,646,000. Operating expenses for the month came in $1.7 million higher than budget. That variance driven by our salaries and wages, of course, with our higher FTEs, hired by about $2.4 million. Benefits were below budget by $246,000. That includes a pickup on our pension expenses. As we finished up the year end, we had really good performance on our pension investments. So we're going to be seeing lower pension expenses as we adjust those numbers by about $648,000 a month. We're still working on our actuarial calculations, but that's our current estimate of what we'll pick up moving forward this year. Our employer taxes were up about $342,000 with our higher salaries and wages. We had slightly higher Blue Shield claims in the month, just $64,000. Pro fees and purchase services for the month were about $500,000 lower than budget. No real standouts there. Consulting, the largest variance there was our consulting costs that were $111,000 lower than budget. But really, this is an area where we've really cut back on our spending, and there's a lot of smaller variances across the organization that add up to that $500,000. Also, our depreciation expense for the month came in about $161,000 lower than budget. December, we really start looking at where we expect to land by the end of the year. And with our curtailment of spending, a lot of the projects that we had intended to do have been slowed down or stopped until we get on a little bit better ground financially. So we ended up the month with a bottom line that was $354,000. Excuse me, I'm jumping. We ended up with operating income for the month that was a loss of $2.271 million against a budget of a little bit over $2 million, about a $227,000 variance in our operating income. Non-operating income for the month came in about $581,000 better than budget at $227,000. couple things going on there. Interest expense with our bond refinancings that we've done over the last couple of years coming down, about a $693,000 variance there. That being offset by our rental income coming in, actually came up about $160,000. That includes a $760,000 settlement we received in a negotiation with one of our tenants who needed to exit their lease early, but that $760,000 offset by lower collections from the existing tenants as they really struggled during this pandemic. So we end up the month about $354,000 higher than budget with a loss of about $2 million. We'd expected closer to a $2.4 million loss for January. Moving into the Financial Accounting Standards Board presentation, and this is the way the financial markets might make adjustments to those GASB financials when they take a look at us. First thing we do is we reclassify our revenue bond interest expense out of non-operating up into operating expenses. There's about $521,000 impact there. So we come up with operating expenses from a FASB perspective, a little over $1 million higher than budget at $42,438,000, and operating income about $433,000 lower loss than expected at $2.792 million. We then we get rid of our revenue bond interest expense and the tax revenue that supports the debt service on those bonds, and our unrealized loss on our investments of about $289,000 to come up with non-operating income from a FASB perspective at $733,000, about $173,000 better than budget, and we end up with a total bottom line from a FASB perspective of $2,059,000. So, there are any questions on those two? Okay, I'll move right into EBITDA. Earnings before interest, taxes, depreciation, and amortization. This is a representation of how much income the operations and non-operating activities of the healthcare system are generating. We do look at our operating expenses before we consider depreciation, which is a non-cash item. So when we pull that out, we come up with EBITDA of $1,652,000, about $388,000 lower than we expected. Likewise, we look at our non-operating income and expenses before considering interest expense. As you can see down in that section, we have non-operating income before interest expense of $1,891,000. So in total, in the month of January, the Washington Hospital generated about $3.54 million in income to take care of some of the needs of the healthcare district. So are there any questions on January?
Yeah, Chris, this is Bill. With respect to the January patient statistics, the case mix index was a record high, and the average length of stay also was as high as I've ever seen it that I recall. My question is when you look at the COVID versus the non-COVID patients, what happened with those numbers, the case mix index and the length of stay for the non-COVID patients? I presume a lot of the numbers that we're seeing was driven by the very, very high volume of COVID patients that we had.
Yeah, that's correct. I mean, just in discharges in January, we had, I think it was 198 discharges of COVID patients. I think that was the highest we had seen. In those cases do stay a much longer length of stay. I don't have the exact number of days at the tip of my tongue, but they are very sick. You know, they're as Mary explained, a lot of them end up with pneumonia, and they stay a long time. Most of them, the majority, I think, are Medicare and elderly folks with COVID that stay the long lengths of stay, and it is really driving those numbers.
Chris, what do we know about anything about the either the federal or state government providing funding like they did last year, as maybe
Yeah,
as a result of the new COVID bill?
Yeah, well, unfortunately, there's no money for acute care hospitals in the new COVID bill. I think there is some money targeted at rural critical access hospitals. I think it's about $8 million.
$8.5 billion.
Billion. A B and an M. But none for hospitals like Washington Hospital at this point. Kimberly, you might want to talk a little bit about the conversation we had today.
Yeah, so there isn't any directly, but there is still discussion at the federal level about trying to help hospitals. Chris and I had a conversation with Diane Feinstein's office and their head of public policy and health today, and talked about our situation and how we're different from other hospitals, because there are some hospitals that have given their money back or don't need it, and that's a lot more of the larger systems who have the ability to spread some of their financial issues around, or they also have other ways in terms of being able to deal with their resource issues. And so that we did talk about our situation and our need, and really where that it's really been that last half of the 2020 is when we saw the biggest surge. And so they are looking at ways in terms of looking at options of being able to put in some additional funds for hospitals. But they're still, they just got done, today with the House passing the $1.9 trillion. So that they are looking at ways that they can bring forward some additional help for hospitals, but that's still in the discussion point right now.
Yeah, we have been told and heard through different channels that their plan was to go right to that discussion as soon as they got this current bill passed. But again, no details and no time frames that we can rely on at this point.
Well, what's different, in terms of the funding that we got last year? Why was that? Where did that come from? And why can't we use the same funding source for this year?
Yeah, that was a one-time allocation of dollars, actually two-time. They did two different bills. There's still $30 billion of that money roughly undistributed, and I think that's all going to come into part of the conversation they're going to have now that they've got this current COVID bill out. But they're talking about targeting that money. I don't know what that means. Hopefully they'll target it to hospitals like us that really need the help, and we're doing everything we can to be chirping in the ears of our representatives. Kimberly's had a number of discussions, I know, in Washington and in the state and at the county. So it's a bit of a frustrating situation. That money's just sitting there, and there's a lot of hospitals, particularly standalone hospitals like Washington, that really need the help. You hear the rumors that some healthcare organizations didn't spend the money they got and they're sending it back. I think, as Kimberly mentioned, that those are largely the big chains, the big healthcare chains. But the standalone hospitals like Washington, for the most part, are having a rough time of it. So.
The other difference is they just haven't opened up. I think the key is they've only allocated funding through June 30th at this point, June 30th, 2020. So that's where we received that money. If they have not yet at the federal level given any money to anyone that is for the July 1st onward timeframe. That is what we're advocating, is the additional help for that time period. So that's the difference right now.
Yep. We still are holding the $57 million in Medicare advance payment funds that are really a loan that we've got to hold back. We really are trying to advocate with the federal government to possibly convert that into, some or all of it, into grants. That would really help hospitals like Washington, but again, you know, until they got this COVID bill done, they really haven't wanted to talk about it.
So is that 57 million included in the cash balances on our balance sheet?
It is, but there's
How
an
are we holding
offsetting
it?
liability as well, yeah.
But it's not in the cash days on hand.
It's not in the days cash on hand, yes.
That's the question.
Yes,
Okay,
yeah.
okay. Well, who is they? When you say they are going to try to get money, who are the they that you're talking about?
I think it's Congress.
There are bills, like Senator Manchin has put in a bill in terms of funding hospitals. So there has to be either an amendment to a bill that's going through. They need to propose it, and then it needs to. There's different ways, as you know, whether it's a bill or an amendment to something that's already going through. So they're looking at different ways of being able to, I want to say, tack it on to something else at this point.
Yeah.
Gee, I'm really disappointed in whatever lobbying efforts that whatever the hospitals use as lobbying firms. They've done a lousy job, I think, in stating our case for, and just not our case, but, you know, probably 80% of the hospitals in the country. Oh, it's disgusting. All right.
Yeah.
Kimberly, do we know where Mr. Swalwell and Mr. Khanna are in this matter?
They both are supportive of it. Again, it's you know, this gets into technicality of what type of bill, this budget reconciliation, and they were focusing on certain things. But yes, Ro Khanna and Swalwell have heard our story and understand the issues that we have. And again, you know, looking for that way to be able to try to advance it. You know, there's a lot of competing priorities too on it. So, but I do feel like they understand where there's a true need for it.
Is there a legislative mechanism which is on the table which they could put their support behind?
So the question is, there was a bill that has been introduced, and so I don't know now, with it not going in with the 1.9 trillion, if that now is a separate one or not. So we need to find that out as to how that works.
Okay, thank you. All right, Chris, anything else, or can we move on to hospital operations for March?
Yeah, I think we're ready to move on.
February.
All right. I am going to present February's numbers, and just to set the stage, you know, we did start off February also very high in terms of our number of COVID patients of over 50, and then as the month progressed, our numbers did drop. In the middle of the month, they were around 30, and then they've subsequently continued to drop throughout the month. So you will still continue to see some of the long lengths of stay driven some through the COVID and non-COVID patients. But wanted to start by the gross revenue. Gross revenue of $167.4 million for February was above budget by $9.8 million, or 6.2%, but below February of 2020 by $7.7 million, or 4.4%. Inpatient gross revenue of $111.8 million was above budget by $10.2 million, or 10%, and outpatient gross revenue of $55.6 million was below budget by $389,000, or 0.7%. Moving on to our key census statistics. Our average length of stay was 6.83, which was above the budget of 4.90 by 1.93, or 39.4%. And basically, it's less than what we saw last month, but still very high, and resulting from the higher acuity of admitted patients. The average length of stay was also longer than the February 2020 average length of stay of 4.96. Outpatient observation days were 40 or 26.8% above budget at 189 days. An average daily census of 154.1 was above the budget of 146.4 by 7.7 or 5.3%. And just to give a little bit of context on the length of stay, our COVID-19 patients have had a higher than average acuity and length of stay. The average length of stay for the 107 COVID-19 discharges in the month of February was 10.6 days, and 15 of them stayed longer than 20 days. We also had some very long lengths of stay patients that were discharged. So these were non-COVID-19 discharges, and there were 3 outlier cases in February with the length of stay of 85, 111, and 247 days. And if we exclude those outliers, then our average length of stay was 5.6. In-house at the end of February, we had 8 patients with an average length of stay of 67.6, ranging from 30 days to 161 days. So we still have a few patients in-house that have long lengths of stay, and there's a team that's really working with them in terms of looking at placement, and that's been we've had some placement challenges with them. Moving on to admissions. Admissions were below budget by 154 or 18.4%. Admissions for the month were 228 or 25% below February 2020. Again, due in part to the shift in joint surgeries from inpatient to outpatient. Moving on to patient days. While admissions were below budget by 18.4%, patient days of 4,315 were above the budget by 217 or 5.3%. This was the result of the longer average length of stay and higher patient acuity that we've experienced during the month. Looking at our surgical trend, total surgical cases in February of 316 were below budget by 16 or 4.8%. Surgical cases were 59 or 15.7% below February's of 2020. Inpatient surgeries were 24 or 15% below budget at 135, and 82 or 37.8% below February of 2020. Our outpatient surgeries were 8 or 4.6% above budget at 181, and 23 or 14.6% above February of 2020. Moving on to the surgical activity, you can see that joint replacement surgeries were below budget by 16 or 10.7%, and joint replacement surgeries were 34 or 20.4% below February of 2020. General surgical procedures were below budget by 9 or 5.8%, and they were 28 or 16% below February of 2020. Neurosurgical procedures were above budget by 3 or 15.8%, and were 2 or 10% above February 2020. And lastly, had a very busy cardiac month. You can see cardiac surgical procedures were above budget by 6 or 75%, and there were also 1 above budget, 7.7% compared to February of 2020. Moving on to cath lab. Cath lab procedures for February of 332 were 1 above budget, but 17 below February of 2020. We looked at the cases, and cath lab cases for February of 190 were 2 or 1% above the same period from last year. Our inpatient cath lab procedures were above budget by 4 or 2% at 203, and 11 or 5.7% above February of 2020. And our outpatient cath lab procedures were below budget by 3 or 2.3% at 129, and below the prior year by 28 or 17.8%. Looking at next at our cath lab activity broken down, you can see our peripheral vascular procedures were below budget by 8 or 5.4%, but 11.9% above the same period last year. Our cardiac procedures were below budget by 1 or 0.9%, and 13.4% below February of 2020. Neurointerventional radiology procedures were on budget and 66.7% above February of 2020. And then non-vascular interventional radiology procedures were above budget by 10 or 15.2%, but 18.3% below February of 2020. All right, moving on to deliveries. Deliveries for February were at 92, which was below budget by 31 or 25%. I do want to mention there have been some articles in the Wall Street Journal and other papers about deliveries and what has been happening and given the pandemic, and saw that the Brookings Institution estimated that there will be 300,000 fewer U.S. births in 2021 than in prior to the pandemic. And really a combination of health and economic crises is prompting people to delay or abandon plans to have children. And we've seen this in other types of situations historically. And so, I think that we, are going to continue to see low. We have spoken with the OBs, physicians. They do feel like their volume is starting to pick up, but it's still, overall, it's not at the levels that they have seen in previous years, and feel that a number of people are either delaying or deciding at this point not to have children. So we'll have to see as time goes on how this reverses. Moving on to non-ER outpatient trend, our non-emergency outpatient visits of 6,539 were below budget by 274%, and this is about 15.4% below February 2020. Again, I think in the past we continue to see challenges with cardiac rehab visits that were below budget by 271 or 44.9%. and X-ray visits were below budget by 179 or 11.2%. This was offset by our lab visits, which were above budget by 253 or 9.8%. Moving on to our emergency room visits, they were of 3,077 were below budget by 762, 19.8%. and below the same period last year by 1,405 and 31.3%. And really, it seems, talking with a number of the hospitals, volume seems to be down in a lot of the EDs, but the acuity and those coming in to receive services appear to be higher. So some, I think, still are delaying coming into the emergency room. Moving on to our gross revenue, emergency room visits were below budget by 762 or 19.8%, driving emergency room revenue down by $2.1 million or 20.2%. Our deliveries were below budget by 31 or 25.2%, driving birthing center revenue down by $727,000 or 23.6%. Cath lab procedures were above budget by 1, but had an unfavorable procedure mix, driving cath lab procedure revenue down by $669,000 or 5.5%. Our total surgical cases were below budget by 16 or 4.8%, but the more additional neuro volume and cardiac surgeries drove surgical services revenue up by $1.8 million or 5.9%. Patient days were above budget by 217, and patient acuity was high, driving room and board revenue up by $3.6 million or 11.6%. And the higher level of inpatient acuity and the longer length of stay drove ancillary services revenue above budget by $7.9 million or 11.2%. Moving on to our payer mix, you can see our government-sponsored patient revenue made up 71.7% of total gross revenue. This is just slightly higher than budget by 0.2%, but lower than the prior year of 1.4%. Our HMO was 2% of gross revenue, which is below budget of 2.6% and lower than prior year of 2.2%. Good news is our PPO revenue was 25.2% of gross revenue, which is above the budget of 23.9% and higher than prior year of 23.5%. And also private pay was 1.1% of gross revenue, which is below the budget of 2% and slightly lower than the prior year of 1.2%. I know finance also did sort of a brief looking at our contractuals in February, and it looks like our contractuals are much better aligned with our budget. So this month may be much closer to budget in terms of our contractuals, which will be beneficial. Moving on to the productivity indicators, our productive FTEs were above budget by 65 or 5.1% at 1,346.6. Our non-productive FTEs were below budget by 8.8 or 0.5% at 173.7. Total FTEs of 1,520.3 were above budget by 64.2 or 4.4%. The variance is driven by volume, that's 20.3, and also we had additional unbudgeted FTEs relating to COVID in terms of resource nurses, our COVID monoclonal antibody therapy, our pre-op testing, EVS, and those are areas that we're looking at reducing now that we've seen our overall COVID numbers going down too. So looking at our productive FTEs per adjusted occupied bed of 5.84 was higher than the budget of 5.65 by 3.4%, and the total FTEs per adjusted occupied bed of 6.59 were higher than the budget of 6.42 by 2.6%. So we were a little bit higher than the budget. So we're working on continuing to reduce those FTEs. Looking at our outpatient statistics, our Whitman clinic visits were below budget in February by 182 or 1.2%. Our Development Corporation visits of 2,460 were below budget by 663 or 21.2%. The main drivers, Washington Urgent Care. If you remember, we have reduced the hours of Washington Urgent Care. Our surgery center was down by 67 visits. Also, Ohlone College Student Health Center remains closed, though we are working with them to do some telehealth visits going forward. Our outpatient rehab center was up by 2 visits, and radiation oncology center, as you heard from Dr. Yoshida this evening, was above budget by 120. All right, moving on to key financial statistics. Our days cash on hand for February ended at 156 days, an increase of 1 day from last month. This is due to a $9.3 million or 8 days of reimbursement from the Development Corporation for advancement of funds for construction with the surgery center, are partially offset by lower patient collections of $2.8 million, an investment loss of $519, and then also higher operating expenses. In March, we do expect to receive $8.7 million from, it's another one of the IGT funds, and it's the Hospital Quality Assurance Fund. But we also will have a pension funding that we will have to do one of our pension funds in the amount of $6.6 million. So looking at our days in gross revenue and accounts receivable, it was at 67. We had higher volume of high dollar, high acuity patients compared to last year. And lastly, in terms of charity care, there are $319,536 in charity care applications pending or approved in February. So that is my report for February.
Great, Kimberly. Is it getting harder to collect, given that we're seeing the increase in days in accounts receivable?
Yeah, it's a combination between, it's just higher account balances when the bills do drop, but we're having struggles with insurance companies because everybody's working from home.
Yeah. Okay.
And they're just moving slower. It's harder to get a hold of representatives at the insurance companies for the simple fact that, you know, they probably only have one phone at their desk at home, and I don't know what they're doing about voicemail, but yeah, it is a slower process at this point.
But we do eventually collect that money.
Yes.
It just takes a little longer. That's good.
It takes longer, yeah.
Good. Thanks. Any other questions from the board members? If not, Kimberly, do you have announcements?
I do have a few announcements. I do want to just thank the board of directors who were able to celebrate with us and participate in the employee recognition event. We were able to socially distance appropriately, and we acknowledged over 100 awardees that attended, and I did receive a lot of really great feedback, and people appreciated that they were recognized and we were able to do it given the situation. So I do want to thank the board members that were able to participate in that event. The next, what I want to talk about is our March Employee of the Month, Anthony Baldessano. He's a certified nursing assistant on 6 West. While many people would say events during this past year made having a positive attitude a little more challenging, co-workers of Anthony would say that doesn't apply to him. Anthony is a certified nursing assistant on 6 West, and during this past year has had a great impact on our patient care. His willingness to listen to patients, tell them little jokes, and offer a little extra time make Anthony a highly requested CNA. His coworkers appreciate his positive outlook and willingness to pitch in when and where needed. Anthony, who was raised in Union City, was encouraged by his mother to become a nursing assistant. She retired after a rewarding career at Washington Hospital and felt that Anthony's caring demeanor would be a good fit. He joined the Washington Hospital family in 2013 and was immediately struck by the supportive environment. He says, there is great teamwork here, and everyone is willing to teach and work together for our patients. Putting our patients first is Anthony's top priority. He enjoys listening to their stories and helping them to get better. Anthony's description of a good day is knowing that he left each patient he worked with a little happier and feeling a little more encouraged. So congratulations, Anthony Baldessano, on being the Employee of the Month for March. All right, the last announcement or little presentation that I would like to do is on our COVID-19 vaccination clinic that I think everybody is aware of. You know, we've really pivoted and put forth resources to ensuring that our community can be vaccinated, and so feel like it's something that I want to share a few statistics that we have with the board of directors. So next slide. So our community vaccination clinic, as most of us are aware, opened on February 1st in 2021, and it's operated in conjunction with the Washington Township Medical Foundation. And we've had basically 2 sites. It's been in the Washington West Anderson Auditorium and also in the parking lot out front. So as of March 7th, we have done 17,645 vaccinations for 11,549 people. And I know that we did another around 1,000 over the last couple of days. So that's the numbers are over 18,000 for the number of vaccinations given. And I do just want to make sure that, you know, we follow the county's guidelines as to who we can vaccinate. So at this time, we are able to vaccinate anybody who lives and works in our healthcare district who is 65 and over, and also meets the tier that is open in terms of childcare, teacher, food, agriculture, emergency services. So that is really the focus that we have had recently in terms of vaccinations for our community. So moving on, this is just, you can see in terms of what we were able to do for those, the clinics that we run Monday through Friday, they're within Anderson auditoriums. We can do 750 per day, but I will say the other day we did over 800, so I know that bar has been raised, and so we feel that we can do probably closer to 900 per day. In terms of second dose vaccinations, we do those in the parking lot, and we can do 1,000 per day, and we do those on the weekends. Looking at our percentages by city, as you can see, this is of the first doses that Washington had administered, and this is of the 11,550 individual people. 57% were from Fremont, 11% from Newark, 6% from Hayward. It looks like we haven't had any from Sunol, 16% from Union City, and then 10% from all other cities. I know it's a little hard to see. Going to Alameda County vaccinations and looking at basically how many have been given at the county level for our 5 cities. So 90,288 have been given. And in terms of we have given 10,415 to individuals, and you can see how it breaks down. So overall, it represents 12%. You can see the highest number again for us was also from Fremont so you can see 17%. We vaccinated 17% of those that have been vaccinated in Fremont, and Newark we've done 16%. So you can see how it flows. And then of course we had about 1,100 that were from other cities. Looking at the percentage of the Washington Township Healthcare District residents who have been vaccinated, so based on estimates of population, we have vaccinated 3%, and the county is vaccinated 14% from Fremont in terms of looking at just the population in general. And this population includes everybody, even those, the young children, anybody, so they may not be at that tier to be open up to be vaccinated. You can see with Newark, we've done 3%, the county overall 15%, and you can see how that goes. Union City, we've done 2%, the county has done 18%. Looking at it broken down by age and gender, we 49% in terms of 65 and older, 75 and older, you can see 4,565, that's about 40%. And then we've done more female than males. Looking at the race and ethnicity of who we've vaccinated, in terms of, we've vaccinated the highest is 38% of the Asians was our highest race and ethnicity, followed by white and Caucasian, then we've got Latinx, and then the African American, and then we have mixed race and others. And then this is on the right-hand side, this is an estimate of the population of our district in terms of the breakdown by ethnicity. The next just shows what percentage of individuals had a history with Washington. So there were about 3,288 patients that were new. So 28% of those who were vaccinated have not had any patient encounters with Washington. About 68% had an encounter within the last 5 years, and then 465 or 4% had encounters more than 5 years ago. And of the total of, we vaccinated 13%, or 1,524 of ours that we vaccinated were Kaiser patients. We're also looking at ways that we can improve our vaccination rate and being able to address the equity issue. I know you hear a lot about ensuring that everyone has access to vaccination, and that's important for us in terms of reaching all aspects of our community. So we continue to look at ways that we can reach out to under-vaccinated populations. And if you can, next slide, please. And then in terms of some of the ways that we've been doing it, we've been looking at some of our current relationships and also trying to expand on those. And you can see some of the ones that we've worked with and been able to offer the ability to vaccinate. I will say that, you know, we worked with McDonald's, and we received a wonderful compliment back from them, from the owner of the McDonald's. And at first, a number of his employees were very hesitant to be vaccinated, and we were able to talk with them and give them information and facts about vaccinations. And they came over, and what they ended up saying was that they felt very respected, and that we really made a difference to them, that you know, they're often not always well respected through people that come in and get the services, but when they came and were vaccinated, they felt that it was very personal, and that we listened to them and answered their questions. And all but, I think, 2 of the McDonald's employees were vaccinated. So we received a very wonderful note from them, thanking us for taking the time to reach out and ensure that they got vaccinated. And then we also have future plans to continue to go talk to other community organizations, places of worship. We're also looking at mobile clinics and going into other areas. Test lab, you know, we have been in discussions with them. We did a first round of vaccinations of 65 and older, and we are working. The next tier that's going to be opening up in March is those individuals that have comorbidities. So we've been working with them, and they are identifying individuals in their workforce that would be fall into that tier. So we plan on doing some additional vaccination clinics with them, and as time goes on, open it up to more of their employees. We've also been communicating with the community through MyCharts, social media posts. We've continued to update our website. We're sending out emails. We're also looking at doing some information cards and light pole banners, again, just educating the community about the importance of vaccinations. One of the things I did mention, to the next slide, is that we're looking at information cards in terms of people understanding, giving them information about still the importance of masking and washing hands, but also information about the healthcare system and who we are. And so that's something that we also so that have the opportunity to give them more information about the services that we offer. Also, as you know, besides the community clinic, we've also vaccinated our hospital employees and others. And so the total number of employees that we have are over 2,074. We've vaccinated at this point 1,709. So we've vaccinated about 82%. We have another 111 that we are still have not declined, but so we are working on trying to answer any questions or concerns that they have, and hopefully we'll get them vaccinated in the near future. The other group, we did also vaccinate a number of our WITNIF and Washington Township Medical Foundation and medical group, our surgery center, our medical staff, and other contractors and volunteers, and that was close to 1,000 that we did. So that was another group of individuals that we have also vaccinated. So just in terms of the challenges with our operations, you know, yes, we received the vaccine at no cost, but we do have to put the infrastructure in place for the vaccination clinics. The other challenge has really been getting a steady supply of vaccine. Unfortunately, we were not able to receive a supply on Tuesday, so we did hold a clinic on Monday and a small one on Tuesday, but we have not been able to do any more first dose appointments. So hopefully in the near future, we will be receiving some additional vaccines so that we can continue to do first dose appointments. So it is hard when it's not guaranteed, vaccine on a regular basis. This is not, I think, a lot of hospitals are dealing with this, and a lot of the clinics are also having to have interruptions or cancel appointments. And so we have not wanted to just book appointments because we don't want to cancel them. We'd rather wait till we know we have the vaccine and then open it up and book at that time. You've also probably been hearing that the state is in the process of transitioning their vaccine distribution to Blue Shield, and they're in the process of trying to work with counties and providers to sign agreements to move to having all vaccine being distributed through Blue Shield. And I think it's unknown how that will work and how successful it will be, and how exactly they can, I would say, try to ensure a more steady stream of that, rather than just putting another layer of bureaucracy. So I think there's a lot of information out there that seems to continue to evolve. And then again, as we all know, the changing of tiers and ensuring that once a tier has opened up, that we can reach out to the appropriate populations and get them scheduled. So those are some of the challenges. But again, we are, as we all know, we're a community hospital. We're here for the residents of this community, and we feel strongly that being available to vaccinate anybody who is a resident who live or work in the district, that's part of our mission to do so. So I just wanted to, any questions, but wanted to give just a little bit of an overview.
Yeah, Kimberly, I often get asked about waste. What are the initiatives that we have to mitigate waste of the vaccine?
Yeah. So we have worked very much to have sort of people on standby that meet the criteria in order to be able to, ensure that we don't have the wastage. So it is not an easy thing to do in terms of really ensuring, and we also have done a lot of calling people, to ensure that they're coming for their appointments, but we also have a list of people and restaurants or organizations that we've reached out to when we see that there's additional vaccine. I don't know, Tina, if you have.
We have a wait list that we utilize each day in order to ensure we don't have any wastage. They have to meet the criteria of the tiers that are open. We don't have walk-ins. I know we get asked that question a lot. Can I just stand and wait until the end of the day in order to get the vaccine? And we don't allow that. We actually, through the call center, we have a list that we have a wait list for those that meet the criteria.
So we've been doing pretty good at minimizing any waste.
Yeah, absolutely.
Yes.
Yeah. We will not waste. We will not waste.
I mean, they about an hour before they have a good sense. We won't open up a vial. We will reschedule if there's something that's happening that way. So, and I know they start getting on the phone calling people.
Yeah, so exactly what Kimberly said. So about an hour prior to the closing of the clinic, we call each of those people that are scheduled to ensure they're coming in. We pretty much then know who's not coming in, and then we know how many doses we have left, and we call the appropriate people in order to make sure that dose gets into an arm.
Yeah.
Okay, yeah. Thank you. Thank you.
Other questions?
No, it's wonderful that we're able to do this for our community. This is really why we're here. And I really have to applaud the efforts of Kimberly and Tina and the whole team to make this happen so well and so efficiently. It's been extraordinarily well received. People are excited to get the vaccine, and they've been most pleased with how efficient the service has been provided. So I think this is a wonderful thing for the community. Hopefully the supply will continue and that we will be able to expand the population that we're allowed to give the vaccine to. Looks like from the statistics that you presented that we're about 20% through the population in getting vaccinated, and we really need to get up there 70, 80% really to have this well behind us. So, and it's good to see such great progress in early March. So thank you so much, Kimberly, and to the rest of the crew for making this happen.
Thank you for the support of the board of directors too. It's important.
Absolutely. Is there a need of a closed session tonight?
There is not.
Good. Any questions or comments or issues that other board members would like to bring up at this point?
I just wanted to add my kudos as well for the vaccination clinics. I just today talked with 2 people, and they could not say enough good things about the entire experience, because they hear about things that are happening in other counties, and for those that I've spoken with, they all want to tell me in detail. I drove up and somebody greeted me and they told me where to park, and then I got in line and somebody was there to help me. And over, all I hear is it was so organized and so smooth and so quick, and everyone was so nice. And I see that too, helping and volunteering and kind of rubbing shoulders with some of these people that are filling syringes or running syringes across the street. Everybody has such a positive attitude, and I think it really rubs off on the people of the community that they're serving. And I think it's just been a great team effort, and we're really shining in a really dark time. So I appreciate the task force for the groundwork that they've laid. Everything has been managed so well, as much as we can control. We know that we can only do what the county allows us to do. But whatever has been in our hands has been handled just so wonderfully. And I'm just so excited to be a part of this and to know that we're making a very positive impact in our community. So please, thank your staff.
Yeah, it's really been Tina Nunez and the staff of the Medical Foundation have really and a lot of, between it's really been a collaborative endeavor. Between pharmacy that ensures that we have the vials and only lets us open certain ones at the right time, to security and everybody else. IT has been another the other thing that we've been able to do is to open up, once we have vaccine again, we have the ability to have people schedule online, and they don't have to do it through MyChart. And so we've been able to open that up and be able, our IT team developed that for us in a really short period of time. So, our call center gets inundated. So this is another way that our community can schedule. We just need the vaccine in order to be able to do that more.
And we've had a lot of volunteers too. So a lot of the medical staff have volunteered their time on the weekends. It's been great to see in terms of that. And then, of course, the Medical Foundation management and leadership has been instrumental in terms of helping with this as well.
Great. Thank you. Any other comments from the board?
Yeah, Kimberly, the only question that I would probably have is, I'm sure you probably wouldn't know this, but, if once we start getting Johnson & Johnson vaccine, I think, the percentage of uptake would suddenly go up because it is a single dose. And is there any indication from the county whether we'll get Johnson & Johnson at some point? Or?
Yeah, that is a good question. We actually have received some Johnson & Johnson, and what they've asked us to do, so the county is recommending that any of our inpatients that get discharged who are 65 and older, that they get vaccinated if they have not. So they've given us doses of Johnson & Johnson to use for vaccination. So it is here. Ed's just showing me the picture that it came in today. So we actually have Johnson & Johnson here. And so we will be using it to do our inpatient. So that's a good point. Thank you, Dr. Epen, for bringing that up.
Go ahead. Go ahead.
Yeah, no, that's it. That's all I was just going to say for those, it is a single dose.
Yeah, well, I didn't know whether Jacob was finished, so.
Oh.
Yeah, I'm done.
Oh, okay, so I've been asked a question that is the people that have already had the Pfizer, they're all turned on about the Johnson & Johnson because of whatever reasons. And so they said, if I've already had the Pfizer, both doses, can I get a Johnson & Johnson? And what would happen? What would happen to me if I got the Johnson?
Yeah, I don't know if Dr. Stewart or Dr. Jeff Stewart, or Mary Boron, but I don't think there's been that they're allowing that at this point in terms of any of that happening. So
I mean, would you die if that happened, or do you know, or does anybody know?
It's unlikely that you would suffer an ill effect, but from a societal standpoint, it's much better to take that dose and put it into somebody who has not yet been vaccinated. That's the thing that's going to help us out the most. It's not increasing your own immunization. It's actually getting a broader spread of people who are immune throughout our community. So I've had that discussion with a few patients who have asked, and I've laid it on the line. Don't even think about it. Don't go there.
That's a good answer.
Yeah. Okay, any other questions or comments? Very good meeting, challenging year. Challenges are ahead of us, and I think we have a good team to meet all of this. So thank you again for all the hard work, and there being no further business before this board, this meeting is now adjourned. Thank you.